Hello, hi everybody. Welcome to the event where we'll speak about women's health. I am very happy to see one man in the audience. I know that he's an attorney. Yeah, this is the correct term. And he works with human rights, so probably that's why you're here, right? Why women are here, I have no questions because we probably experienced the reality of being a woman ourselves, right, in many situations, and healthcare is probably just one of the examples. First of all, I would like to thank UNESCO for Migle and Liliana and everybody working there, and Lithuanian Journalism Centre for making this happen, because this is not a very common topic to speak about. But the fact that we are here today and that we have even guest speaker from a different country is one of the results of a work that has been happening for many months. So yeah, today we will have a guest speaker, Professor Alkistis Skalkidou from the Uppsala University, and she's a founder of a whole center. It's an interdisciplinary center together with Karolinska Institute. And she has already published over 120 scientific papers. Out of them, 100 is about women's health, related to women's health. So she has been doing that for many years for the good of all of us. And also we will have a panel discussion afterwards where you will be able to ask your questions. I have my questions ready, but you are free to ask your questions. And I think it is much more interesting if you participate in the panel discussion as well, because it makes the discussion much more relevant to all of you. And you came here to learn, probably to know more about the topic, so this is the right time. We will also have Ramunė Grikšienė participating in the panel discussion. Hello. She leads the only scientific group in Lithuania that is focused on women's health, and she's a neuroscientist. And she was one of the first ones in the world to publish a scientific paper about the fact that hormones affect our emotional state, right? That there is a connection. And then we have Gražina Belousova, a sociologist, that will help us connect the dots in the society. So without further ado, please welcome on stage Professor Alkistis Skalkidou. Yeah.
Thank you so much. Thank you for the wonderful invitation to such an inspiring day. We have been meeting with government officials in the morning, and now it's the most important players, which are you, and you're sitting here Friday afternoon, so you must have a very high degree of dedication. So we thank you so much for being here. My name is Alkistis Skalkidou, and I'll try to give you within 45 minutes a little bit of information about my personal journey as both a woman, a researcher, a mother, to also talk to you a little bit about my research in women's health in different life phases, but also give some general recommendations based on our experience in Sweden. So I will just start with a very summary of the things we talked about in the morning session, that women live longer right now than men, but spend more years in poor health than men. And that's around 9 years in a woman's life is spent in not so good health. And that is something that should promote that we need to do something about it. We also know that many female-specific conditions remain underdiagnosed, undertreated. There's a lot of stigma around them. There is this notion that, okay, you won't die of it, so just bear with it and you'll fix it. Don't whine. A lot of that in women's health. We don't include women in clinical research because we think that it's very hard to account for the menstrual cycle, or if they're in menopause, or if they're pregnant, and it's so complicated. So it's better to just take like young men and just do everything on them. It surely applies to women also, which it doesn't. And we've seen that in, for example, all the medicines that have to do with sedation, anxiolytics that are given in doses to women which make that they cannot drive their cars because they're falling asleep on the wheel because they were tested in men. So the doses are totally irrelevant for women. And then we say, oh, it's the women's fault. They can't even have the medicine. Then we also don't talk a lot about sex differences in disease in healthcare. Many of our studies, for example, on heart failure or myocardial infarctions are in men, and we do not recognize these conditions in women because we are waiting to see the CTG, like the results like in the men's studies. And no, it's not like that because women present with different symptoms. So we're losing a lot of women that we could save just because we don't know how to diagnose them well. So we have gaps. We have a lack of funding for women's health research. Only 5% of all research funds are given for conditions that only affect women. Of these, 4% are on breast cancer or gynecological cancer. So it's only 1% of the total research funding given to other conditions, like everything else that we have to meet as women. So it's really, really low. We often focus on women as reproductive vehicles, and what does it mean for the children, and so on. So focusing on research around like women giving birth to the next generation, but not to women themselves during those times. We don't take the research results directly into healthcare for women quite fast and easily, and we do have a gender bias in medical knowledge, as we said before. So for me, so that we go from this a little bit like distant kind of like background. To me, I was born in Athens, so it's also a country where, gender equity is always also struggling. We strive for equality, but we're not there. I went by the US for high school, and then I went back and studied medicine in Athens. I did my PhD under two men, which were amazing mentors and really, really giving equal opportunities to everyone. So I'm very thankful to them. And I learned about epidemiology, which is the science of noting differences, patterns, and associations, which is what most of the research is about. Then I said, what am I going to specialize? And I like hormones, but then I chose the hormones that have to do with women, and I became an obstetrician gynecologist, which is an amazing medical specialty, being near women in different phases of their life, and all the hard but also painful, but also can be quite exciting times of their lives. Then I went to Sweden. I moved there, and I've been living to Sweden since. I started my postdoc in a postpartum depression study, and then it quite went well for me in my career, and I became a professor in 2017. But while I did that, I also have my children. So that is a personal example of how you can combine your aspirations and hopes with having children if you choose so. My personal experience of working in the area of only women's health, but also mental health. So this is even more of a niche. If women's health is underrepresented, women's mental health has been kind of like totally ignored for a long time. I started my postdoc in 2005, and during these 20 years and after the 250 papers I wrote, I have seen increasing trends and engagement, but we do focus more on breast cancer still, which is very important. We have reached amazing survival rates for breast cancer, which is super. So I think that this is now time to move also to other things that really affect women. So in Sweden, I'll be talking about the whole center, which focuses on mental health and pain condition. I also see a lot about this kind of like risk factor-based research. Okay, we know that your risk for something increases when you have this or that risk factor, but we need now to move to holistic predictive models that can help pinpoint individuals with high risk to develop a disease instead of trying to, when they've gotten their depression or their endometriosis or all this, trying to help them a little bit too late, too low energy. So we really need to go to prediction. But I do see, especially in Sweden in the last years, an increasing recognition of women's health as a public health priority. And I think this is good and should be spread out more. So what I think has worked in Sweden is that we have tried to increase awareness of the gender differences in health. It's not like women are overrepresented in all disorders. Men have their difficulties also, so we do know that they also have some things that they need more help with. But it is very important to try to lift also what we have not looked at, and women are the ones we have not looked at. I started off with cancer, but now we're moving to also other areas, mental health and pain, one of them. We have had national initiatives to support the women's health research, and this, I think, is central. We have developed interdisciplinary research centers, and we are trying to move to policy and to go into the healthcare system. So funding, targeted to women's condition. All funding applications in general, they have a paragraph on a gender perspective. How will this be relevant to the genders? And if you don't include men or if you don't include women, you should describe why. It's not that you shouldn't do it, but you should describe why. And also the researchers themselves, you need to be fair in giving funding to an equal proportion of women applying so that you help women researchers follow the academic path in fair terms. And the results are beginning to be visible, I think, in Sweden. So some examples, we have now in Sweden improved knowledge and screening for peripartum depression. We have better recognition of other gynecological disorders. We do, as you will see, more research on menopause and aging, and we do more collaborative work between the disciplines, which I think is of paramount importance. Every discipline have a different perspective, and to solve such complicated problems, we need to work more together. But if you see the whole picture, we still have less funding than other fields, and it's a little bit slow translating from research to practice, especially because funding of healthcare right now is like we work with negative budgets all the time. I think the situation is here the same. So it's a little bit of a difficult period to implement things we're learning in research, unfortunately. But how can we help this? Yes, we can work more with national guidelines based on the evidence. We need to collaborate more between universities and hospitals. The public health agencies should be using research results more, doing like literature reviews, and we need to work more with register-based and longitudinal clinical cohort studies. Some examples that we see very much improved. We see that maternal mental health now has a screening. I don't know how it is here in Lithuania, but we screen women both during pregnancy and after childbirth for mental health with the EPDS. We have improved obstetric care programs. With this new chromosomal abnormality screening and preeclampsia prevention. And we do a lot of work in HPV vaccination and HPV sampling. So cervix cancer rates are going down a lot. These are just some examples. There are much more we can do, but I do want to say that all of this is possible in a framework where we try to follow equality policies. We have a strong parental leave system, public healthcare access, and a very big focus since very many decades back on maternal child health. And of course, there is a lot that plays into how we influence political decisions, because all goes down to funding, of course. I will need to move on, but this is, maybe I do like that. No? Doesn't want to go? Ah, no. Okay. So I'll talk about the centers now. Let's see here. Yes, the first center that we had, and that was established in 2020, is the GUMHR, which is the Center for Women's Mental Health during the reproductive lifespan. And we did quite a lot of lobbying to get this center, and I hope that it can be an example on how we can do in other countries. And the GUMHR produced a lot of PhD students, a lot of research, and got quite a lot of recognition that made the government starting to map out what are we still missing in women's health. Apart from mental health, we also have the pain conditions and so on, the menopause focus. So after they mapped out, they came out with a big funding scheme that they said we will be funding 3 major centers in women's health. And one of these centers is the Whole Center. The center was created as an answer to this need for a health center. It focuses on disorders that are for women or predominantly by women. We cover the whole life course and we connect research and healthcare. This was funded by Forte, our governmental funding agency, with 6.7 million euros for 6 years. The 2 other centers were cancer and postpartum care. Our center, as I said, it's 6 + 4 years. It has the goal of improving women's health in a life course perspective at the intersection of how reproductive transitions affect mental ill health and pain. And it's by Uppsala University and Karolinska Institute, and we have 17 disciplines and 45 senior researchers in this center. So the money given, you understand, is not like a huge number for 45 senior researchers, but the fact that they're putting us together and giving us the possibility to interact, we hope will create synergies and more projects in this. And you see here the range of conditions that are under our umbrella. All these conditions have to do with mental ill health or pain in a life course perspective in women. And right now we look at them very, very separately, while often many of these things are interconnected. So we are trying in one of our work packages to merge them. So our mission is that we will work through the disciplines to create new knowledge, innovative care models, and we'll work in close contact with patients with lived experiences, and we'll disseminate back to society. We will develop, educate young researchers, and we aim for policy change. And this is the mission. And I will stop here. And I will be happy to answer any questions. Thank you.
Thank you very much. That was a very interesting presentation. And we
And now I'm going to get you through a little bit about what I am doing and some examples of problems we have through the center. And this is the mental health aspect and the gender depression gap. And you see here it's an old study, but you see that the difference between women and men being depressed is mostly during puberty, at childbirth, and at menopause. And this is repeating in other studies. Here you see the differences, how like women have much more of the anxiety and depression disorders, while men have more ADHD and the conduct disorder, addiction, and the full suicides. So we are very different, but you see like who is the mostly affected. You see the bars. They're just, depression and anxiety are so prevalent. It's such a big problem, while the others are not that, like, it's not often we see it. Here is a very recent Norwegian study that you see also the girls, how much they are affected during puberty in relation to boys who are not as affected. Of course, there are boys not feeling well, but we are talking about this huge difference. And going back to the menstrual cycle, as a gynecologist, I mean, I need to get you there. And you see the hormonal fluctuations in estrogen and progesterone through the menstrual cycle, right? So it's a roller coaster. You go up and then down. Some are so sensitive that they get a little bit of PMS symptoms after their ovulation, right? Because estrogen goes down. Then it goes up again, it's okay for a week, then it goes down, both estrogen and progesterone. In general, estrogen has a mood-enhancing effect, progesterone has an anxiolytic effect. If you go down in both estrogen and progesterone, you're going to be both sad and irritable. So yes, this is PMS. And we said before that when you know your menstrual cycle and you know that you're in this last phase, then it's half the treatment is that you know, okay, these are some days I'm going to be not myself. The others know, and they can leave you a little bit alone. It's okay, you're coming back. You can do something else during these days. It's like, you know about it. I don't say it's like you should totally disregard it, but you respect the fact that you have a hormonal impact on your brain during these days. It's very important to know. And there are diagnostic criteria for this, right? This is a disorder. It's like in the DSM-5, that's a psychiatric manual. Many women, like they often once a month, they want to quit their job. They have suicidal thoughts. It's a serious thing. Oh, sorry. And here's the burden, and you see like morbidity, 14.5 million disability-adjusted life years in the US. 40% during symptomatic phase have suicidal thoughts. Like this is quite of a big problem. If we go to childbirth, we gynecologists usually say, like, if you want to know what's going to happen to you in life, just get pregnant. Because, like, if you have a sensitivity for diabetes, you might get it. If you have high blood pressure problems, you might get it. Mental health, you might get it. So it's if you want a mirror into the future, yes, please. So it is a very big stressor for the body, and we really need to acknowledge this fact. And you can get a lot, sorry, it's a little bit, you can get a lot of depression and anxiety, the trauma symptoms, the OCD symptoms, like recurring thoughts about harm or things, and the postpartum psychosis, which is 1 in 1,000, but it's very, very grave, and someone else needs to really catch this and report to others, and of course the suicides. This is statistics over any form of treatment for mental ill health during pregnancy, and you see from 8% to 13%. That's like huge numbers. Any form, like even psychotherapy or a contact. This is 1 in 10, so it's big. And this is the hospitalizations, and I guess you understand when childbirth is, right? So after giving birth, you have a huge drop of hospitalizations just because a lot of women are so vulnerable from this drop in their hormone levels after the placenta comes out. And despite the fact that in Sweden we have all these points of like meeting women during their pregnancy, we still have 4 to 5 dying every year, despite the fact that we see them. We see them like every month, but still we miss them. And you would say, why? How didn't you see that? Because women are so good in hiding and pretend. It's such a stigma and it's such shame not feeling well during pregnancy and childbirth. And we are afraid to ask. So it's a tango, right? It takes two to tango. So we need to be better. Consequences for society are huge. Politicians understand numbers better. The problem is that among all the women depressed in childbirth, we only treat rightly 1/3. 1/3. Yeah. And this is because we don't have this, it's twofold. There's one that we don't have a very dedicated care pathway. Now we have started with the screening and the follow-up, but still we're kind of yeah, I see you're high on the test, but maybe you didn't sleep well for 2 days. Yeah. So if it doesn't get better, get back. Who among the depressed patients gets back? It's that's what depressed patients cannot do because they don't have the energy. Plus these have a baby to care for. So it's not a valid care pathway to say, yeah, just contact us back. And it's also very hard because this is not like a one risk factor thing. It's a biopsychosocial problem. You need to have both a biological sensitivity or that you might have lost blood during delivery or things like that. You need to have also the social determinants, not a lot of support, violence in the relationship. And you also need to have this low resilience or things. So all of this needs to puzzle up. And that's why it's very hard for midwives that just see 1 or 2 things at a time and don't put the whole thing together. This is the roller coaster I was talking about, that the hormones are so high up and then they go down, and that leaves women in a period of vulnerability. So if you would see women going through their pregnancy and postpartum and their mental health, you see that Lina down there, I mean, she goes through a lot. She goes in a real depression, but then kind of tries to climb up again. And right now with the screenings we screen them there in mid-pregnancy and postpartum. So we have totally ignored Lina, who has gone through her depression alone and so on. So it's just screening like that doesn't really help. We want to go from this model where we find this little red circle with 16,000 women with perinatal depression. We need to have a model where quite early on we can see that Lina is going to be depressed. We can predict that she does in order to put in interventions. So we need to also have this big yellow circle with women that we identify as high risk to get depressed. So we will intensively give them a lot of support in order to prevent them from entering these other circles. So we need a stepped care approach. There. We also work with the patients a lot, the patient organizations, and I go into menopause because this is the next phase. Menopause is not only vasomotor symptoms, which you see up there. There are a lot of mental symptoms. There is a lot of vulvovaginal symptoms. And we need to meet all of these and help our patients. The symptoms are not there for 1-2 years. They can last up to 14 years, which is not fun at all. So this also needs to be taken into account. You know that after 2002, we had these big studies that proves to be a little bit biased and not very well done, introducing menopausal hormone therapy very late when it's risky. And now we know that menopausal hormone therapy, if it's taken transdermally and with other methods, in close contact to the menopause itself, is not risky. So we need to change how we think about this. We know that apart from hormones, there are a lot of other things to do. Each woman is their own universe, and each one can choose among all of this we have to offer. And we can't say a package, same package to all. We need to see the family. What kinds of cancers do you have in your family? Is it more like cardiovascular breast cancer, or is it endometrial? And try to find preparations that pass each individual woman. So we do now, with the help of the Vetenskapsrådet in Sweden, a very, very big study with national service and interviews with women and their partners, actually, register-based studies and a multi-center double-blind study that will help us, I think, to find individualized advice. One of it is, for example, for the risk for cardiac infarction. After starting MHT, we see that there is no risk if you're taking transdermal preparation. There is no high risk if you're taking estrogen-only preparation. So most of the risk is from tablets, and it's only in the first year. So then we can say to women who have this profile in their families, you should take gel and patch and not a tablet. Then it's okay for them to take. This is what we mean by individualized therapy. So the way forward is to individualize care, to offer different preparations, to advise, to discuss risk benefits, and do not forget lifestyle, habits, mental health, and the alternative therapies. The International Menopause Society has a lot of material and resources for women, because we are trying to educate healthcare professionals, but as you said here, a lot of them are not in the loop yet. But women should be empowered to look at validated evidence-based advice from international organizations. So lastly, some few personal recommendations that I also had in the morning. We should be better at funding research for women, include both sexes in all studies, try to look at women's health as a lifelong approach and not individual moments in their lives. Focus on these conditions that are not life-threatening, but they're very, very burdensome, and move towards prediction, prevention, and public health instead of running after established conditions for years. Collaborate with our colleagues in different disciplines. The medical professionals mean well, but we don't know everything. We don't understand everything by ourselves. We need input from everyone else, and work closely, of course, with people with lived experience. So I think there is a big opportunity for return on investment in this area. We said in the morning, for every $1 you put in, you get 40 back after some years. It's like a huge gain. It's just that you have to trust this and really wait out this period. Early interventions to reduce the long-term healthcare costs. Invest in these population studies, what women say themselves, put in a health economic parameter so we can give more to the politicians and promote policy alignment with the scientific evidence. So let's see if it wants to change. This is for me, and thank you so very much for your attention today.
Thank you. Thank you, Professor. Yes, please sit down. We will have a panel discussion right now. As I mentioned before, You can ask your questions. I will provide such opportunities. And as Alkistis stated, in the morning we had a roundtable discussion with our policymakers. We have advisors from ministries, vice ministers, and so on. And we try to convince them that this is a highly important topic. However, we now see how even in real-life situations, even if you are provided with scientific facts, politicians often find ways to deny them somehow. But yeah, so please welcome on stage Professor Ramunė Grikšienė. Yes. And Dr. Gražina Belousova, sorry. Yeah. And I did not introduce myself. I'm Goda Raibytė. I'm a science journalist, but yeah, this is not about me, so maybe. Okay. Oh, I feel very important sitting here. So when we say that women's health is under research, what do we actually mean? What it means to you? Maybe, Gražina, let's start with you.
So I think one of the things that we need to talk about, I'm going to speak specifically about Lithuanian context, right, is that when we start asking questions, right, whether we are asking questions about women's choice to have or not to have children, how many children to have, or any other kind of questions that have to do with women's reproductive health, but also overall health, there are many more social factors that we do not know than we actually know. I need to do a little bit of a preamble to what I say, right? So I'm a sociologist. So unlike epidemiologists or unlike medical researchers, what I'm looking at is I'm looking at social conditions which affect health outcomes, right? That's what I can speak to. So when we look at socioeconomic conditions that affect health outcomes and women's decision in relation to their health choices, there are more things that we don't know than we actually know. I'm going to use something that's been very resonant over the last several weeks in Lithuania, which is the question of demographics and why women choose to have fewer children. Truth be told, when we strip down moralizing and politicizing, there are very few things that we know that come into that decision-making process, especially as it affects women who are vulnerable socioeconomically. Right. So for me, as a sociologist who works on women's issues, I do not have good data to give. Why? Because there is no research. And as such, that research then cannot impact epidemiological studies. It cannot impact any other kind of studies. It doesn't exist because there is no funding. So that is what I would say.
Ramunė, how does it show up in real life? I know that you conducted a study where you have some results to share, right?
Do you expect me sharing results? Maybe I just would like, first of all, to continue what it was said here. So for me, this underfunding means, again, that I don't know what we know all, that the Alzheimer's disease is twice more often for women than men. Politicians do not believe in that, and we were discussing this morning. However, we know that it's true, but we don't know during menopause, whether we should take hormonal therapy, whether it helps somehow, when we should start taking it, which type of hormonal therapy could help better with dementia and to diminish risk of Alzheimer. And there are many other disorders which we as neuroscientists, we don't know. We would like to know that, we would like to study, and another issue which I suffer with underfunding, that we cannot get funding for our studies where we want to study this and to try to answer at least some questions for helping women. And please remind your question.
About your study, because you recently did a survey about symptoms that women experience.
Yeah, it's about, we are starting a study on women mental health for young women in reproductive age suffering from premenstrual symptoms, and another study on perimenopause and early menopause. And in both these studies are going to be longitudinal. We are going to measure brain functions in the beginning of the study, and then to apply interventions, hormonal therapies and psychotherapies, and then to see what happens with brain functions. So what we already know, we just started the study and we performed survey on premenstrual symptoms. So more than 1,060 respondents responded to the study, mostly women, mostly menstruating women. 95% of these women said that they perceive milder or stronger premenstrual symptoms. And the type of these symptoms, it's not just physical symptoms which we can manage just taking painkillers. The symptoms are emotional and behavioral, anxiety, irritability, what was just mentioned. And we don't know what we should do, how we can help these women. Knowing about this, it's, as Professor Alkistis just mentioned, only knowing that these symptoms are related to the specific period of the cycle and they will vanish in few days would help. What we know from our study, that 67% of women, it was 300-something women suffering from very hard, severe symptoms, and 67% of these even do not know anything about this premenstrual disorder, PMDD, premenstrual dysphoric disorder, and 62% of them never reach healthcare experts seeking for help. So, yeah, we should increase awareness of public, of women, and also partners and families seeking to help these women.
Thank you, Professor Alkistis.
No, I totally agree with you. For me, I don't have the YouTube video title now, but there was an amazing clip on YouTube where I think Lisa Galeas did from Canada about the total discrepancy between the amounts that are being spent on research on cancer versus the amounts that are being spent on research on women's conditions in particular, but also the number of scientific papers and breakthroughs in the two categories. And of course, I mean, the amount of research and results we have is a correlate of the funding. That's why we often talk about funding, this 1% on women's conditions apart from cancer versus, so one of the whole. Well, of course you have other heart conditions in women, and this is, we hope it's been within the rest of the 99%. But even there, the problem is that the studies do not look at women specifically, and many of these studies are only men. So it's both ways. It's both among the studies that should look at both sexes, they underrepresent women. So we don't have results applying to women. And it's only 1% for the women-only condition. All the obstetrics, all the endometriosis. So it's this is what we're talking about.
You also showed us a chart of different conditions, women versus men. There was autism, that men get autism more frequently than women, but there has been some discussion about the diagnostics, and that autism is maybe better diagnosed to men than to women because women experience different symptoms. Can this also be a problem, one of the issues?
And it's not only autism, you're totally right. Also, the distribution between the sexes has been changing. So now more women are also diagnosed. So this gap is closing there. But also in ADHD, we see now a new, not phenomenon, I think it was always out there, but we are now realizing that women in midlife are getting more ADHD, which we thought were only children. So it can be that these conditions affect men and women in different life stages. It's also true that many can hide symptoms of ADHD because they are very highly functioning, or they have from life experience been able to multitask and just fix things. And this is an ethical question in general in mental health and pain. Are people that have a higher threshold being punished because they just can go through with life? Because one of the criteria for the psychiatrist is this function. If you can keep function while you have symptoms, it's like you're not getting the diagnosis, but you're suffering. So this is also a big question. If women, for example, theoretically could still deliver despite the fact that they're greatly suffering, is it fair? Because they don't get the diagnosis, because function is a part of the equation. So it's a lot for us to dive into and try to understand to achieve equity and quality.
One project calculated and published the results on Nature that it's around 0.5% of neuroscience studies were meant for women's health. So conducted until today, basically. So that also illustrates very well on situation that we are at. Grażyna, you wanted to reflect a little bit?
Right. And so when we talk about studies that are being carried out, I think something that we need to think about is also research design and research questions. So these are true studies that were carried out using the little money that we have on women's health that is not directly related to cancer. So, for example, such studies as the impact of menopause on women's male partners. You cannot make it up, right?
But they're counted within the 1%.
Right, right. Or the sexual attractiveness of women going through perimenopause to males, right? So when we do have, right, this very limited funding that's available globally, part of that funding that is related to women's health is directed actually not at women. It is directed at measuring men's satisfaction or experience of women's conditions, which is funded from the same pot, but we cannot call that legitimately research about women. This is not women's research. This is actually men's research that perpetuates the same question that's been asked in much of reproductive health, is how satisfied is the man?
And there was one study in Italy, but it's an older study on whether women with endometriosis are attractive to their partners as well, and whether they get less attractive when the disease progresses, which is, they actually funded the study, many thousands into the study. Ramune, I also have a question for you. Alkistis in her presentation mentioned about the symptoms of PMS and so on, and that they are diagnosed. It's a diagnosis. In Lithuania, we have a different situation. Can you
it's
please?
The premenstrual dysphoric disorder.
Yeah.
I think PMS, it's treated as a gynecological disorder, and it is diagnosed here in Lithuania. However, premenstrual dysphoric disorder is completely different. It's a mental disorder. It is including in DSM-5 and the TLK-11, two systems which are not introduced yet in Lithuania. So this is the reason why nobody here, I don't know, somebody is diagnosed, but probably from the abroad. Here in Lithuania, it's just impossible to diagnose the premenstrual dysphoric disorder. And I also, after our event on premenstrual dysphoric disorder last week, I heard one comment, one doctor gynecologist, she said, nobody would like to be diagnosed with this. It's just, so I was thinking, really, do you think that they wouldn't like be diagnosed? They wouldn't know, they don't need to know what we are suffering from, and to be able to get this precise treatment or at least some advice how to deal with that. But this is a thinking among medical doctors. And
So how can it be treated if it's not diagnosed?
No, I agree with you. And I think many women don't know that it can be treated. Of course it can be treated. We have both like menstrual regulation strategies to take out the ovulation that triggers all of this. We have SSRIs, SNRI approaches. With hard cases, we have the GnRH agonist approach where we close the whole system and give a little bit of add back estrogen. So, and then we have CBT approaches also. So, of course, it can be treated, but exactly as you say, if you don't diagnose it, how are you going to get treatment through the system? It's a step. And of course, I mean, the comment could be that, okay, you don't want to get diagnosis, but it's like if you have cancer, yes, you don't want to get a diagnosis of cancer, but like, I think everyone wants to have a diagnosis if they have cancer because then they'll get therapy and they most likely will survive, right? You can't just do like that.
Yeah, because the disease will progress.
Yeah.
Meanwhile,
And also what I think is very important that they know that there's something biological happening in their body and it explains their symptoms. It's not just their personality, lazy person or something. It's a biology which affect and they should be explained with this. And this is a halfway to feel better.
maybe you have questions for our panelists. Yes. Maybe try and speak, and if we can't hear you, I'll bring you a microphone. Yeah. Can everybody hear her? Perfect.
First of all, thank you for bringing attention to this topic. I think it's very important and quite forgotten. But I have a very selfish question, if that's okay. Since you're women of science, maybe you can help me. I'm a student who's aspiring to work in women's health research, and I often encounter a particular challenge myself. That is when I focus on structural issues affecting women. The criticism I receive as a student is often framed as methodological. For example, that the topic is too political, too biased, or not specific enough to the population of women. And this raises a difficult dilemma for early researchers like me, because if we pursue these questions, we risk academic penalties. That means we receive worse grades, which indirectly complicates later pursuits in academia. But if we avoid them, as we're talking about now, structural problems remain understudied and unseen. So my question is quite simple, but probably also difficult to answer. What advice would you give to young researchers who want to study systemic issues in women's health, but encounter these kinds of institutional barriers? Thank you.
Wow, amazing question. Thank you for sharing that. Who wants to answer? Who wants to start?
My answer to that is yes. And that persists beyond early career researchers. I just had a conversation with a colleague of mine who submitted a paper on women's experience of childbirth, of women who have, of neurodivergent women, experiences of childbirth. And in in the references that she received reviewing her paper, she was accused of activism, and she's rather than science, and she's an established researcher. So this persists, and I think that this is you are right to name this, and it is systemic, right? It persists from all the way from the way that research funding is allocated to the way that PhD supervisors are trained themselves, to the way, to what is granted institutional legitimacy, to existing literature in the field, to conference topics and conference keynotes, all the way down, even to the advice that bachelor students receive while choosing their thesis topics. How do we change that? I think where I see the change happening is I see the change happening with women who enter science. Unfortunately, not every woman who enters women's health field as a scientist is going to be an advocate for women's health and inclusion of women, because they were trained also in a certain system, right? It's not necessarily that they're bad women. They are products of a certain system, and unless there have been opportunities for reflection, and a certain willingness to take academic penalty for engaging in research like that, it is very hard to find those openings. I do not have good advice to give because women's health per se is not my field. I cannot tell you go there or ask this. What I can do is I can validate your experience and to say that what you're experiencing is not individual but systemic.
I am working in biology, so I've started 30 years ago this topic, and as student, as you now, and as bachelor student, and it was really hard at this time. Nobody believed that brain and hormones interact, and then menstrual cycle or hormonal contraceptives can be related somehow to mental health issues, to cognition and everything. And it was really hard for me to go through this alone here in Lithuania, only with my mentor, and I was receiving different comments from doctors, from medical doctors, gynecologists, and others. Who are you? Why do you think that you can speak on this? And why you are investigating this? But now I am where I am. I have a group. I am studying, and I am not afraid to speak on this. And I think in this area of biology and neuroscience, we do not receive any more such comments that it's not important or political or yes, we do not receive enough funding, but we can do our research if we want to do, and if we are able. So just go ahead, do this, what you believe on, and then you will succeed.
It is weird to hear the phrasing, I am not afraid to talk about it, because this also illustrates very well the structural problems that we have, that if we talk about certain scientific topics, we experience some pushback. This is.
But I mean, in the States now, they don't fund anything on gender, women, like it's, we are at that stage, right? So we should be happy that until now in Europe, we can still work on them, and a lot of American colleagues have thought about moving. What I want to say is, apart from my colleagues and validate your concerns, is that you don't go into this field if you kind of are a careerist, or you want to just go quickly up on top. You go because you really, that creates meaning for you. And what is a positive note from my side is that you will find a very cool group of other people working in the field, because no one goes here who doesn't want to be here. So at least on that part, you'll have good company.
Do you think joining some international projects maybe, or mentorship, could help in these kinds of situations where students are feeling that they cannot pursue careers in this topic because they are still considered controversial? Ramona, or
I think absolutely, and I think we are being very good in societies like SNRP. We have a mentor system. The Marseille Society has such a system. ECNP now, so both more biological, but also interdisciplinary societies on women's mental health. I'm talking about, because that's my part, are doing a great job in mentoring and also networking, connecting each other. We have a lot of EU cost actions where we meet, and events where we promote young researchers. And I talked a lot about the Swedish centers, about this capacity building, that we all need to really support young researchers in this area, because these are the people that are coming after us, and we want them to be more than us. So yes, I totally agree. This is a good idea, and we are already doing well in this direction, but we need to work more.
What I can really confirm, as Alkistis said, that you meet some of the coolest people in the field, and this is true. When I started exploring this topic, the women there, because it's usually women, of course, I mean, it's just like you are impressed by all of them and you are inspired by all of them, and that really motivates you to push, to keep on pushing, because you see the company you're with. Right? More questions? Yes.
Hi, everyone. My name is Renginį. The topic of today is obviously very well chosen, and the fact that I'm here today in absolute minority shows that the topic is definitely very needed here, and I'm grateful for the fact that it's publicly available. Now, I don't feel sorry for the men that are missing out today, this valuable discussion, because I'm here for myself, and as someone who has in family, the majority of my adult life, I've been taking care of a woman who is now of honorable age, and I've seen the life stages, and I want to emphasize one important thing. So many young women here today also. Youth is a thing that passes inevitably, and I have also lost young women in my family due to health things that are completely preventable today. I have seen that. I have realized how life stages go on, and now I can feel a little bit more educated, learning from the hard experiences. But anyway, I think it's very important to emphasize that global situation where the population is aging, we have to so strongly focus on the later stages of life, especially women who tend to live longer. And now that I have one in my household, I see what challenges I have to face every day. And it's very different from young women, what they experience. Some of the charts I can confirm by personal experience. The levels of depression definitely go up even after you fix the biology in later stages. So anyway, but at the same time, I can say that it seems that it's way better than before, than decades ago, when we could not even have basics like HPV vaccines, for example. So much better. So my question is now, do you think it's really insufficient and ineffective in terms of research, and especially in private field? Because has there any time in history been more attention to this topic, and especially in the private field, when, for example, such trending topics like obesity research and metabolic syndrome, huge markets, huge capitalist markets that are very heavily invested into by greatest pharma companies, they're spending so much research. Do you feel that there is also gender disparity when researching, introducing new drugs, new therapies to the markets, or in the private fields? Because half of the population are women, and the private companies should be interested in covering this part of the market. Is there gender gap too, in your view? Thank you.
I just wanted to say that this latest Lancet paper said that from femtech startups, only like 9% is them, like dedicated to just women's research. And I do understand that the obesity drug market now and so on, it does affect women as well as men, of course. But we're talking a little bit about the women-specific disorders that are really predominantly among women. That's where we are lacking, I think. But you can come.
And I think it's very hard to investigate women. So if pharma company wants to investigate something, some drug related specifically for women, it should be highly motivated to do that. Maybe have something specific as you shared in their families and motivation, because it's hard. You should follow menstrual cycles. You should be very careful regarding pregnancies. You should think all the time. It's more, I don't know how many times more expensive, more complicated, and it's much harder to expect results. It might take, for example, for our premenstrual disorder study, we were like set or perspective, to warn by our colleagues from other European institutions that it will take 10 years, for us to have to complete this study. So yes, I think there are some pharma companies which would like to do this, but it's really, really hard to do that.
And I think that something that there's also a gap between what is developed in the labs, what is developed in our R&D departments, and what becomes available commercially in the markets, and what the governments choose to see as essential medication and actually cover and compensate for. Right. And one of the things that we see globally is that even in countries that have some of the best healthcare systems for women, there is a disparity when it comes to compensating medications and procedures that are specifically related to conditions that affect women. Yes, I think that my colleagues are much more competent to say what happens at the when it comes to development, right? But once something is available, to whom is it available? How is it available? At what cost is it available? And so on and so forth. So we begin asking other questions, because it's one side is development, the other side is health policy.
I just want to also say, for example, we have now had in Sweden all these years like this trial for contraceptives for men, and it takes just so much longer, and and there are negative side effects. Yeah, hey Sherlock, of course, but or we gynecologists see like a lot of women going through sterilization procedures where it is like a very big procedure to come in and in the abdomen, right? While for men, it's just so easy outside, but still among couples, men refuse to do it. So there is still quite a lot of, how much can you take in order to achieve something? And we really have to work around it. Yeah.
Thank you. Amazing questions so far. More questions from the audience? No? Okay, I have my questions. You can think of yours. As I said, it is much more interesting if you participate as well, because we can see, like we had 2 questions so far, and they were so different, but also eye-opening, right? So maybe this question is more for Professor Alkistis and Professor Ramune. Maybe you can give us examples, like concrete examples, how male-based models still affect healthcare system today, and from your personal maybe experience.
I think I named so drugs is one, like the drug dosages, and it's not only the ones that I named about the anxiolytics, right? So dosages are made for a standard white male, and they work totally bizarrely among women, of course, because it's too much. Or it's too little, because both the mass of the body and the liver function and the amount of blood in the body is very different between the sexes. So all drug preparations, because of constraints in individualizing the dosages, right? Especially for vaccines, for things that are not like you take half the capsule. That can be more easily adjusted. They are tested mainly on a standard like white man. So this is for anxiolytics and for depression, like for everything. I think cancer doses also, they try to adjust more. And then I don't know about the diagnostics. I usually give the example of the infarct, that we do know that women have different presentation in the EKG, like the heart function representation, right? So when a woman goes to emergency care with on her chest like pain, maybe she doesn't have this kind of like typical that it radiates. So she may be hyperventilating, so they don't find the EKG findings, and they say, okay, it's a panic attack or it's something else. And then women have much higher probability to die on this stage, while men, they have the typical symptoms, typical EKG findings, so they go directly for thrombolysis and they are saved. So these are just examples, but you can see that in many, many other things. There's a lot, like from gynecology also, that women go to the general like emergency room, where often it's missed that they are pregnant, extraordinary pregnancy, for example, and it delays a lot when they are operated on. They say, okay, but they give a lot of morphine, which is not needed in this situation. You just need to operate very quickly. So these have also been examples of how we miss out because we don't think about women-specific problems when treating.
Yeah, okay, maybe I can add something, because I'm not medical doctor, so I do not have the specific examples regarding to health issues, which is maybe a little bit about some absent knowledge. For example, sexual health, sexuality. We all know probably that male have this erection dysfunction, and we all know this treatment which can be applied. Do we know anything about women's sexual dysfunction, except that they probably are just cold and do not willing to have this? So do you believe in that? Probably not. Do we know? Do you know some treatment? Yes, of course. I believe that doctor you would know, but not.
Yeah, but I mean, it's a very good point, because it is, we don't know a lot, and we give like testosterone to postmenopausal women, and maybe some of them don't feel well on testosterone, but we don't have something else. We don't have something like as Viagra for men. Another big problem is the drug preparation. We are sitting here in 2026 and have half of our estrogen preparations not in the market. Just because, whatever. Women don't really, they can stay without their estrogen therapy. No, they can't. Like you have to have preparation. And now we don't have patch, then we don't have gel, then we don't have enough spray of estrogen. It's all the time like we have to be begging. We gynecologists give 3 different prescriptions and say, whatever you find in the pharmacy. This is never the case for Viagra, which is kind of like not so important as the estrogen medication, because it's, And then we used to have testosterone for women's dose. They took it out because it's not enough women that need it. It's not, the pharmaceutical company says we don't need it. For a time, we don't have bioidentical macronized progesterone and dihydrogesterone that are bioidentical alternatives to menopausal hormone therapy, because these are all medications and they're not making profit. So we go back to what you're saying, that we are in an economic system that promotes profit. The people with money are males, and so everything is driven by their needs. and not by all medications that would work really well in the female population, but they're not making enough money, so they don't care.
Okay, it's difficult to follow that up. Gražina, you as a scientist of sociology, what happened in our society that we started normalizing what is not really normal, that we started normalizing women's symptoms without wanting to reduce it to just simple, sexism? Or is it that simple? I don't know. How do you see that from a scientific perspective?
Okay, so I'm going to start with, yes, it is sexism, but no, it is not simple. In many ways, the social structures of society in which we live are such where women's exhaustion and depletion and poor health, poor self-reported health are taken to be the standard and the norm. Women's pain is taken to be the standard and the norm. So, for example, 58% of women patients in this was an international study, have reported that they received delayed medical attention despite having reported pain. Why? Because women's pain is seen as normal, especially if pain is related to the reproductive system. It is expected. It is in some ways an essential, is understood to be an essential part of womanhood, to be in pain or discomfort because of the reproductive system. The other thing that, so for example, women who report fatigue, the study did not report numbers, at least not that I recall of right off the bat, but there was a study, once again, an international study done very recently in the last 2 years that looked at women patients who complained of fatigue and men, and compared it to men who complained of fatigue, right, in ER or to their GPs. The study stated that women's complaints of fatigue were severely underestimated, despite the fact that fatigue can be a whole host of very serious medical conditions, ranging from hidden anemia, where the red blood cell count presents as normal, but the iron stores are low, to thyroid disorders, to perimenopause, to you name it. Right? Fatigue is one of the most common symptoms that is presented. Why is that normalized? Because we expect the woman to be tired. In Lithuanian context, but also this goes globally, right? A woman, we have the economic conditions such that 2 salaries for a family with children are necessary. It is not economically viable to live off 1 salary, which means that both the man and the woman work 40 hours a week, but the woman works additional 25 hours or more per week on household chores and care responsibilities at home, which means that a woman is working at least another half-time job, and that is only in quantifiable hours. This is actually, if you want better, this is better. It used to be worse because men participate in household responsibilities more now, which means that women, in essence, really worked a second full-time job at home. Anybody who is working 2 full-time jobs is going to feel exhausted because this was such a widely, widely represented symptom, fatigue, that presented among women. It has got normalized. This became the clinical norm. Pain became the clinical norm, right? So all of those things that sort of resulted from social circumstances and moralization and normalization of women's suffering reflected back onto medicine. And so medicine and society became 2 self-mirroring mirrors where these standards are reinforced. And so what we get is we get, yes, sexism, but sexism that has been medicalized, institutionalized, and moralized. Because a woman who perseveres and endures in spite of discomfort, in spite of pain, is seen as a valorous woman.
I would like to argue a little bit here with you. I completely agree with this with importance of pain normalization, that it's a big issue. But I'm thinking regarding these duties, family duties and household, isn't it on us as women to decide what was discussed already in the morning? We decide together in the family who takes care on children, who takes all responsibilities, and whether we share it or not. As I understand, there are some partners with whom it's hard to agree probably, but in most situations, we as women, we are probably trained because of our traditions that we should do everything, but one day we can just decide, okay, let's be equal, let's do it together, and then we can share this additional half working day per week between us together. So who can do this for us if we wouldn't?
I'm actually a living example of that. I mean, in my household, it's strictly 50-50. We are co-parenting, and I said, I'm a feminist, I won't allow there's 10 times more of unpaid labor to happen at our house, and it works. Questions? Yeah, of course you can respond, sorry.
Yes. I mean, I think that this is the desirable, the ideal outcome, right? And I will celebrate every single woman who does that. But I also have deep empathy for women who live in social and economic conditions where that does not become possible, right? Because it's also generational, and in many ways it depends on available economic resources, right? Because if the partner refuses, and sort of the question is, in case of divorce or spousal abandonment, can the woman support herself and the children, right? So I want the world where this is an option for every woman. And I mean, this is why I am in social sciences, right? Like this is why I do what I do, because this is the world that I want for women. But this is ideality towards which we are working. But the reality, right? The hard, unforgiving numbers still speak of a world that is different.
And regarding the different world, for my EMBO fellowship, I was interviewing neuroscientist Dr. Antonella Stantuccione-Chada from Women's Brain Foundation. And she said, you know, God, I have this anecdote running. So the Swiss, she resides in Switzerland, and she conducts her research in Switzerland. And she said, you know, the Swiss government said, okay, let's fill the gaps in research. And they said, take 5 million francs to fill the gaps. 5 million, amazing. It's better than nothing, better than in most of the countries. And I said, amazing, that's a very good government, right? And she said, but wait a minute, you know how many millions they gave for elephants in zoo parks to support, basically, to feed them and look after them? 70. So they gave 5 for equality, and then they said, maybe elephants are more important than women. So, yeah, this is a sad anecdote, but it comes from, you know, the world. Okay, more questions, maybe. Yes. Microphone, because we have a live broadcast, so, you know, everyone can hear that who's not here.
Thank you. Yeah, another question. So I feel frustrated with, as probably most of us are, and I think it's important for us to acknowledge, of course, the issues, but also I keep thinking, so what can we do? Like as individuals, as researchers, what actions can we take? Of course, there's like just civic engagement in general, like voting and making sure that we vote for politicians that stand up for our rights and similar. But and you already talked to some political officials, and you've noticed how difficult it is to influence their opinions. So how do we do it? How can we approach this question, each and every one of us? Because it feels frustrating, but I also want to redirect that energy into changing something.
Amazing question again. Best questions from the audience.
Yeah. No, I can start. I guess you have. I think it's very important to include men in this. We are working together. We shouldn't make this a conflict. We should see everyone as human beings, and how can we do this into a better world? And because if everyone feels valued and respected, that's where we want to go. Then I guess it's very important to continue with small and big things, try to, from everyone's position, from the students can do their things, their actions. We from the academia can do our actions. You from different societies, journalists. So if everyone tries to promote this in the small ways possible, but also to keep repeating that we do need to focus. So don't let the interest goes to war here, war there, so here, there, and let the interest die, and try to find a momentum, work through countries, and do even small things to just keep that on the agenda. I think that's for me important, but of course you guys have more ideas.
My ideas might be completely different. I would like to say that's not my piece of pie. I would like to go to the lab and just to do my research, to plan, to design, to think what is important, what I want to do, how to build study, and how to help women. I'm really thankful to Goda, who catches this topic and who promotes it. I am really happy that we have communication specialists helping with this. Today we had lunch with from Nordic countries minister office, and he said that you need diplomats to go and speak with politicians. So I would really want to have men and women coming and helping us to reach this. We, as scientists, we do a lot. We should know statistics. We should know how to plan, how to record, how to improve equipment, how to get money, how to write proposals, everything. And this additional work, it's exhausting. So yes, I understand. We should speak, we should talk, we should think what we talk. We should educate and increase awareness. But I would like to leave this discussions with politicians to somebody else.
Yeah. Understandable. Gražina?
I think that we have traditionally understood society to be fragmented, that academia does its own thing, journalists do their own thing, activists do their own thing. But I think there's something that I see a greater need for, and that is building consortiums, building broader platforms, right, that do allow the scientists to do the work in labs, but that also are able to say, look, women's health is something that affects more than 50% of the population and 100% of the country, right? And so how can we build those broad coalitions where this understanding already exists so that they can leverage then the social, symbolic, cultural capital that they have to influence political decision-making? Because I do not see how we can move forward without these broad coalitions. Because this cuts across so many different fields. The other thing that is much more cynical is that, unfortunately, we need to translate that into economic terms. Right? It is absolutely pitiful and pathetic that to save women's lives, we need to put $1 or €1 amount on them. But that is, unfortunately, the language that is spoken in the hallways and in the halls where decisions are being made. That, to me, is in many ways the tragedy.
We need to somehow end this panel discussion, but I want some hope, you know, something beautiful to end with. Let's see. Oh, a question. Okay, one more question and then my last question. Okay. Wait for a microphone.
Okay, so I wanted to ask a question. I myself come from medical field. I study medicine here in Lithuania, and I wanted to ask a question related to, we can see that, for example, in a lot of European countries, I assume it's similar, that a lot of women enter health sciences and start training as doctors and go into medical field, because we also associated with caretaking as well. And I wanted to ask, do you think in the future it might also help this situation that women's health will be also receiving more attention, because also a lot of way more women are working in the field and becoming doctors themselves?
Interesting. Nice. Do you want to comment?
Yeah, it's a super interesting question, and I don't think I have an answer. Theoretically, I do agree with you that it should, theoretically. What I'm afraid of is the increasing ethical pressure under which we operate as doctors. And I am afraid that as women, we're going to fix it, and we don't complain enough. If it was like our colleagues from 20 years ago, they would never agree to work under those terms we're working now. Very few of us, too much workload, no time to recuperate. Not to be negative, but I have this fear that the eventual positive side of being more women within the board, like the doctors community, can be balanced negatively by worse conditions while working, unfortunately. But we have to think that, oh my God, what would happen if we didn't do it? So I do think that at the everyday level, yes, it will help. It will be more understanding in different roles and so on. I really hope that the politicians understand that we cannot keep being pressured like this. Because we will break. It is a very difficult profession to work near human pain all the time, and we need to have a little bit of breathing space. I hope that the AI technologies can be a positive influence, helping us out on the side, but I do hope that we have enough of hands to hold our patients with, and more women, it's more hand holding, and I think that will be very good. It was a very good point raised from you.
Thank you for coming here. I mean, and squeezing in your busy schedule this trip as well. Knowing that you're so busy.
I could never say no to you, Goda.
I will use it.
You're so inspiring, and I think what you you arranged here today with the UNESCO Council and the Nordic Council, it's really amazing, very inspiring, and I hope we can take it to the Nordic level. Yeah. We hope we have such a day with all of us together.
Yeah, one day. So I would like to close this panel discussion and thank Lithuanian National Commission for UNESCO, Miglė and Liliana, who did most of the job for these two events, for these two really important events. Thank you all for coming. It's Friday afternoon, Friday evening. Instead of going to a bar and relaxing and chilling out, you came here to educate, to learn, and especially about this really, it's not a very easy topic. It's not easy to talk about it. It's not easy to learn about it and to know the reality that we are living in. But thanks again to UNESCO, the National Commission, for doing this. For taking this challenge. We knew it is not easy, but they kept on doing it, and it's just the beginning, right? And thanks for the amazing panelists. Thank you for Alkistis for coming all the way from Sweden. Thank you for Ramune and Gražina for sharing your insights and for not being afraid to talk to our politicians who were not, let's say, very open, right? But we will get them there. This is the power of us, of educated women, right? Of evidence-based approaches, and hopefully, if we meet again in 5 years, the situation will be better. Thank you for coming and for listening, and thank you all.
I would like to add something, and we are having the best science journalists here. Last week, I was talking with the one professor from Germany, Julia Sacher, and she said, "You are having Goda in Lithuania. We do not have somebody similar to her."
But Germany has Julia Sacher, so they are all right.
So I think we might expect that will be much better in 5 years, because we are having scientists working on this, we are having doctors interested in that, and we are having media interested in that too. So
thank you all. Let's give thank you. Okay, that's it. Have a nice Friday.